Hey guys. Okay, so this is the review for facial trauma, chapter 29. The facial traumas are categorized into three different, um, complexities. So Lefort 1 is the nasoethmoid complex fracture. So it's basically going to be this part of the face. The Lefort 2 includes the maxillary area, and the Lefort 3 includes the orbital zygoma fracture. So basically, as the numbers go up, the fractures become more severe. So, let's see. So our priority with these patients are going to be airway assessment for gas exchange. So we want to look for signs of airway obstruction. We're going to look for a stridor, which we know is a medical emergency, shortness of breath, dyspnea, anxiety, hypoxia, hypercarbia, decreased O2 saturation, cyanosis, and then loss of consciousness. First, we want to establish the airway. So airway. So second, we want to assess for trauma in the site for bleeding and fractures. We want to look for a leaking CSF from their ears or nose. We want to assess their pain, any facial asymmetry, and also edema, because we know edema can cause airway obstruction. And then we want to look for the classic battle sign, which is the bruising behind the ear. That's going to come with a skull fracture. So if they have a skull fracture or you suspect one, make sure and look behind their ears. We want to be prepared for emergency intubation, tracheotomy, and cricothyroidotomy. And then it just stresses in the book timing is critical, especially because head injuries tend to bleed a lot and we don't know what's going on in there if it's really bad. So we want to make sure we stabilize any jaw fractures. And then for the jaw fractures, patients can have fixed occlusion. So they'll wire the jaw shut for 6 to 10 weeks. And then if it's a really bad fracture, then they can do the ORIF surgery. And then, let's see here, which is the internal fixation. So, and then for the facial trauma, they can also do microplating, where they use little tiny plates in the face, and then they can use bone grafts, of course. For post-op teaching, especially with the fixed occlusion with the wired jaw, we want to make sure that we teach them oral care is very important. They can use a water pick or Sonicare toothbrush. They're probably going to be on a liquid diet, so we want to also consult with the registered dietitian. And then the big box in our book is wire cutters. Make sure that these patients are taught to keep wire cutters with them at all times, so that if they, for whatever reason, start vomiting, they can cut the wires and not aspirate on their own vomit. So I think that's pretty much it. So facial trauma in a nutshell. Thanks, guys.